Well, we want to welcome you to Medicare School Daily. I have with me in the studio one of our great agents. Evan Cruz does a wonderful job, been with us for a long time now, and he's joining with me today, and we're excited to be with you and excited to take your questions. Let me just give you the call-in line because we'd love to hear from you today. The number is 833-824-2004, 833-824-2004. Now, we're going to be talking about IRMAAs, but whatever's on your heart and your mind, you can call in today, and we'll be happy to at least try to help. Usually we can answer the questions. We'll certainly do our best to give you some clear direction, whether it relates to Medicare or Social Security or really anything investment-wise we're happy to deal with today. So we are thrilled to have you with us today. Evan, let's get into our topic. Let's talk about IRMAAs. So first off, let's define that acronym IRMAA. It stands for Income Related Monthly Adjustment Amount. And so it's kind of a mouthful. And so the IRMAAs, I think, actually started back in the days when Obamacare was passed, the Affordable Care Act. I'm pretty sure that's when it was. It may have been before that, but I think that's when it was. If not, it's been around for a while. And this is an issue that those of you that are high income are going to have to deal with. And sometimes that high income could have been a previous high income, not just presently. So we're going to get into the details of IRMAA. The title of really our show today is the two most common ways to get stuck with an IRMAA. No one gets stuck with an IRMAA, but you may, and so we're going to discuss that. So first off, let's give them the definition again of the IRMAA. What's the acronym stand for?
Income Related Monthly Adjustment Amount.
All right, sounds good. And so when it comes to IRMAA, I'm going to let you explain, Evan, because you know how this works. But let's talk about the financial numbers that really determine whether we're going to pay an IRMAA or not. So kind of explain that whole formula and that system, and then we'll kind of dialogue more about that.
Absolutely. So the obviously why an IRMAA? Why does it exist to begin with? And so it's usually people who make more money is designed to pay more money into the system because the system is built in such a way that everyone kind of needs to pay their share. That's kind of the idea behind IRMAA. And so if you're making more money, you're going to pay more money, but that doesn't mean that you're just going to stay that way. That your incomes change, your financial situations change, and sometimes they don't, in which case you're doing great. Keep doing what you're doing. If you're earning more money, I always tell people, then don't change a thing. Congratulations. Yeah, you'll pay more in Medicare, but
great problem to have.
It's a great problem to have. Who cares? You're making more money. That's the point of the system. Absolutely. And so the way it's designed is there are different tiers, different brackets of how much it is you earn, and it's based on either you're filing income individually or filing as a married couple, filing jointly, or a married couple filing individually. It's everybody's a little bit different in how they file their taxes. But ultimately, based on how much you make is how much you're ultimately going to be paying. And as time goes on, they're always doing that 2-year look back. So they are strictly with blinders on. Only this year, it's 2026, looking back at 2024. And that's all they look at. And they look at the number. They don't even necessarily look at how you got to that number. They just look at the base number and they assume that that's what you made last year, this year, next year, and every year for the rest of your life until you tell them otherwise. So it's very important to inform
So 2026, looking back at 2024, what are they looking back at?
They're looking back at your modified adjusted gross income, the total amount that you earned, not just your earned income from your job, but anything that you're getting from IRAs or 401k distributions or selling a house or anything and everything that shows up on that line, that modified adjusted gross income line, and that is a total number. That's what they're looking at, and that's what they're going to be varying. And that's what they're going to be assuming that that's what you're making this year. And they rely on you to tell them it's not that case if it's changed.
Yeah, exactly right. So just so you know, that's line 11, AGI. And what Evan is saying is correct. All the income that's subject to taxes is going to be there. And then they're going to add line 2A. Most people don't have anything on line 2A, but it is tax-exempt interest. So if you're an investor in municipal bonds or I think they call it like foreign national bonds, those are not federally taxed, but you still have to report that on your return, line 2A. So if you're curious to know what your modified adjusted gross income is, look at your tax return. Again, 2026, they look at 2024, line 11 plus line 2A. And so if that will be above the thresholds, then you're going to have an IRMAA. And as he said, it's a great problem to have. It's annoying, but it's still kind of the way Medicare is going to work. And remember, these numbers are recalculated every single year. So next year, 2027, looking at 2025. The money we're making this year will not matter until 2028. So that's the system So those of you that are high income, let's just talk about not all the thresholds for sure, but let's deal with the baseline.
Sure.
So the single, let's deal with single filers and then married filing a joint return. What are those numbers this year?
Sure. So just the first two lines there. So, if you're under 109,000 or less as single person or single filer, you're going to be looking at the same 202.90 for Medicare Part B and no additional cost of your prescription drug plan Medicare Part D. It's going to be the base of whatever that plan is that you're on. And
no IRMAA.
No IRMAAs, no additional cost to those. As a married couple filing jointly, it's 218,000, and then anything once again that or less, and then no additional cost on B or D on that one either. Just one bracket up, which is usually where some people kind of fall in that line where it's just over. That's usually probably the most common IRMAA, I would say, is just over the line. And it's only about $81 or so more. It's very, very, it's not a earth-shattering amount of money more. Right. So it's not going to double it. That's the next bracket up where it doubles it. But it's only about a 30, was it 218 is going to be 219 to 237.
I've got a single filer would be 109 to 137. A married filing a joint return, that first IRMAA level is 218 to 274.
270, they got a lot bigger. Yeah,
exactly.
I usually looking straight at the numbers and have it right in front of me. Yeah, so it's a pretty big window of time there, or window of space there, but it's not that much money. I mean, $81. Yeah, it's not fun to pay that additionally. And usually, like I said, when you're on that line. Usually you have just retired or it was a one-off situation that you were finishing up that year, a couple of years before. And so that's where it comes into letting them know and getting it taken off.
Right. Let's talk about that. But before we do, though, let's remind everyone that if you have that high income, not only do you pay more for B, but you also pay more for your drug plan as well. And so that first level of IRMAA on the drug plan is $14.50. Right. So what he's saying is you have 81 extra on the B, $14.50 extra on the D. So someone in that income bracket would have a $95 total IRMAA. And so then, of course, they just keep going up from there.
Right.
All right. And so as we discuss this whole idea of IRMAA, Evan was saying that this may happen because you just retired, but sometimes their income continues to stay up and they pay IRMAAs their whole life, which is truly a great problem to have. But what we want to talk about today during our segment here is to make sure everyone knows that there's really two common ways that people get stuck with an IRMAA that would just be somewhat out of the ordinary. All right. And so let's deal with that. First one would be people not realizing that all income is going to count. So we'll have people, I had a guy not long ago that his daughter had a very expensive wedding and pulled a sizable amount of money out of his IRA. And of course, that's now reportable income, and that pushed him into the IRMAA. It just did. And so if someone's going to do a Roth conversion or any kind of a large withdrawal from IRA or 401k plan, that is going to show up. And so your income by itself may have been below the threshold, but when you did that withdrawal, now it pushes you into the IRMAA bracket. All right. And so that is one common way, not realizing all income is going to count. The second one is when people don't realize that they're going to get an IRMAA and they don't appeal an IRMAA, right? And so that's how they get stuck. And so let's walk through the whole process. Someone applies for Medicare. They're notified that they're going to pay a certain amount for their Part B premium. So they get this IRMAA letter. And so when the IRMAA letter comes, what should they then do?
Yeah. So that's what you're looking for, because there's really nothing you can do until that letter shows up in your mailbox telling you're going to owe. Because if you try to send in some appeal months or in advance, they don't know what to do with it. They're going to throw it away. So once you receive the letter, and even if it's a little bit later than you expect it to show up, is when you can take action. And so the easiest way I would recommend doing it is contact your broker to help you. I mean, when you have questions about stuff, their job is to not just sign you up on a plan.
Yeah, we help people.
Exactly. It's to help you manage this stuff, answer questions you have, get it turned in properly, and most importantly, filling out the form properly. Because when a lot of people I've had who overthink it or try to put in too much information, and it ends up getting kicked back. They go, well, they rejected my IRMAA. You said I'd get appeal. I said, well, there's a good chance it's going to get appealed. That's literally what it is. It's not a guarantee. It is an appeal. But it is mostly successful. And as long as it's filled out properly and correctly, and you fill on, there's very clear instructions on what to do with that and getting it filled out, and take it to your local Social Security office is what I normally recommend doing, because submitting them online. Can they submit IRMAAs online? I can't even remember if they
Well,
can do that.
the new system is supposed to allow that. I still would try to drop it off or fax or mail it into a local office for sure. But the new SSA system is supposed to allow that. Again, people can always try that. I probably wouldn't at this point in time. There's still. I think the new system is going to be great, but it is early.
Yeah, and and just as everything else, when you're submitting things to Social Security, there's no harm in redundancy. I mean, if you send it online, you can send it in person, you can fax and mail it to. And if it's already been done, they're going to toss it. If it's not been done yet, or you got it in the hands of somebody who was a real stickler and looking at the rules and they weren't sure they wanted to go through, it may end up in the hands of somebody else who looks at it and goes, this is all in order, looks good to me.
Right.
So it really is, which is what a lot of people don't like. People like a lot of set rules and like when this is done, this is supposed to be done this way, it's just great if you're doing things the right way. But when you're talking about Social Security and Medicare too, a lot of times you're going to deal with people who either don't really know what they're doing or haven't been trained a lot in what they think. Like people think, well, I called Social Security and they told me this. Well, unfortunately, the training isn't the same as everything. Why do you go to a doctor for a second opinion? Not all doctors know everything. So it's the same thing in the Social Security office. They're not all trained the same. They're not all at the same level. So when you do have somebody who maybe rejects your appeal, it may not be because your appeal was wrong, because it ended up in the hands of the wrong person. And so this is why a lot of times I do recommend, if you are having a lot of trouble at your Social Security office with Medicare or the appeals for IRMAA, maybe it doesn't hurt to reach out to a different office, because sometimes you will get better results if you go to somebody else.
And I think really one of the important things you said there was to make sure that you don't appeal until you get the letter.
Right.
People are anxious, they want to plan, but if you do that, they will not process that. It has to show up in the system when that appeal shows up, that reconsideration, that indeed you have one, even if you know you're going to have one, unless the local office knows that. So don't try to appeal until you get the letter. Right. Now, the letter will say they want you to appeal within 10 days because they would like to get that process before it's going to actually show up in some kind of a bill. But if you did not, you procrastinated that or whatever, it's all right to appeal. I think they'll actually backdate about 6 months, if I'm not mistaken. I think I've seen that, where retroactive 6 months.
I've seen
even farther?
Huge retroactive, even further. And so,
good.
And they're not, U.S. government, of course, is not great on refunds, but they are very good at credits. And a lot of times they will credit you going all the way back, sometimes all the way back to January. Now, I tell people if it's September and they had no idea that they could appeal and they're just now looking into it, get it done as soon as you can.
Yeah.
Don't put it off, because going back years behind and asking for your money back, they're never going to give it to you. But if you can go ahead and get it in now, at worst case scenario, in many cases, they'll stop it now. Will they credit you going all the way back to January? Absolutely no guarantees on that. But I have seen it.
Yeah.
I've seen it done. I mean, they can move mountains in those offices if they feel like doing it. Depends on who you get sometimes.
All right. Sounds good. Well, that's the IRMAA. Let's also talk about the most common reasons that people can appeal an IRMAA. For those of you that this is going to be an issue, the form you want to look at, and you can easily find this online, is called an SS-44. SS-44. Now, a couple things about that form. Number one, it's an 8-page form. You do not have to submit all 8 pages. You only have to submit 3 of the 8. Pages 4 through 8 are actually all the instructions. So the first 3 pages is what you would submit, but there are 8 different reasons for submitting. Let me just go through them real quickly. Could be death, could be divorce, could be marriage, work stoppage, or work reduction. And so those are your common 5: death, divorce, marriage, work stoppage, work reduction. Now there's 3 others. That if someone goes on there, they can be a little bit confusing. So let's talk a little bit about those. The first one would be, it says loss of income producing property. Loss of income producing property. So some people look at it and think, well, that means I owned some kind of rental property. I sold it and took a loss. Doesn't mean that. It means that you no longer have that. It burned up in a fire. It was destroyed in a flood. It was in California and went down a mudslide. So in other words, you had it 2 years earlier, but you don't now. And so the way to prove that, of course, would be insurance documentation saying that you no longer had that property. I've never helped someone with that one. There's also one that's called loss of a pension income or an employment settlement agreement. I've never helped anyone with those yet. My career, all the others I've helped with, but those three never. But the point is, you have to have a life-changing event that's on the list of the 8. I've had scores of people say, well, I did a Roth conversion or I had a stock option buyout when I retired. That's not on the list at all. And so it has to be one of the 8. And remember that when you do appeal, it can't be, well, I'm going to retire in July. No, you have to appeal after the life-changing event. So that's the two things people have to realize. You have to, number one, don't appeal until you receive the letter that you're going to have an IRMAA. Number two, it has to be after that life-changing event. Okay, so let's go through that just a little bit. So someone starting Medicare in 2026, they look at 2024.
Right.
So what do they do from there?
Yeah. So let's say you're starting Medicare January 1st this year, 26, and you applied back in September to get started, or you were taking Social Security and you were automatically enrolled in Medicare, so you didn't have to go online and do it. Usually that letter comes around mid-late December of the year, few weeks before, month before at the most usually, is when you get that letter from the U.S. government saying, hey, look back on your taxes, you made X, Y, Z, you're going to pay this much money. As soon as you get that letter is when you can start that appeal process. Now, as we said before, too, sometimes that letter shows up a little bit later than you expected. Maybe you'll get a huge bill for all your first 3 months of Medicare, including all the IRMAAs and everything, and go, holy cow, I did not expect this much money to be coming in that I have to pay for. And so what do I do? It's a big question. Do I pay all that now? I mean, do I have to pay all this right now? I put in the appeal. I just turned it in. I mean, what do I do? Well, as we said, they're good at credits. So they give you time, and if you go ahead and pay, and you go on to Medicare.gov, and you can pay 1 month at a time if necessary on some of that stuff, they can break up how your payments go. But if you overpay, they will, in many cases, be very prompt about crediting you and for future payments. So don't worry about it. Just as long as you get your stuff turned in as soon as you get it, and you keep moving forward with how you're supposed to be doing your appeals, you shouldn't have a problem with that kind of stuff.
All right. That sounds good. Well, and we want you all to know that when you're appealing, basically what you're saying is that you're saying you looked at 2024, but I had a life-changing event in 25 or 26.
Right.
That allows me to appeal it. So what you're doing in the appeal process is you're saying, don't look 2 years back. I had a life-changing event that affected my income. And so you give them new numbers, and you can give them either one. This year you can give them 25, or you can give them 26 if indeed the life-changing event occurred during that time. And they truly are glad to drop off the IRMAAs. Another thing about IRMAAs, I will have some people that maybe continue to be high income, but maybe 2024 they were really high income, had a very high IRMAA, and maybe their income does not go below the threshold, but maybe we move down a level or two.
Right.
And folks, it is well worth your time to appeal an IRMAA if you can just reduce it 1 level, 2 levels. Okay. All right.
So what would you say to somebody who says, my income's going down to either all the way down or to a lower bracket, and it's, oh boy, it's going to be close to one of those lines, real close. Is it even worth it, would you say to that person?
I would say I would for sure. If it's going to possibly be below it, I would go and appeal, because they're going to go back and check anyways. And if you were wrong in your number, then they're going to bill you for that additional amount. So I would definitely go ahead and take the time to
exactly.
to appeal.
That's exactly what I say. So, it's always better to appeal and be wrong than not appeal and look back and say, hey, you know what? I didn't make that much money. Can I have my money back? They're never going to give it to you. So.
Well, I've had people that really pushed it, who knew they weren't going to be below those thresholds, but they went ahead and put the numbers in and ran the risk. That is crazy.
That is crazy.
I would never, ever do that. You definitely want to be honest, because trust me, they're going to go back. Now, it may take them a year before they do the audit, or 2 years, but you will be caught on that.
Get a big bill for that.
Yeah, definitely.
Yeah.
And you're
not going to go to jail for doing that or anything like that. I mean, I've had some people freaking out about that. Like, what if I'm wrong? I mean, what kind of penalty? I'm like, no. It's nothing like that. But they will get their money. And they're good at getting their money. But like I said, if it's close, I always recommend the appeal, because you never know. I mean, you may end up being a little bit less than you thought. Yeah. And there's no problem if it's close and you're not being dishonest. This is all a guessing game.
Yeah,
they want to know
your
your best educated guess, and they're relying on you to tell them that. And it's like I said, they don't want to take more than they have to, but they do want to take what they're owed.
Yeah, exactly right. Yeah. So that's really, really good. Okay, well, I just want to make just one more statement to those of you that are married that file a separate return. you will get into IRMAAs very, very quickly. And I'm not telling you how to file your taxes, but I'm saying I definitely, as you approach Medicare age, it'd be a good idea to make sure that you're still happy with the decision of file married with a separate return, because you hit IRMAAs quite quickly, very rapidly, and they're very high. Anyway, so I hope that helps. Love talking about this issue. I think right now about 15%, maybe 20% of all people have IRMAAs. That's going to continue to grow for sure. And those of you that work with us as your broker, we will help you fill out that paperwork. Of course, you have to submit it, but we're delighted to make sure that that paperwork is done correctly. All right, sounds good. Well, appreciate the comments on that. And if this ever becomes an issue for you, if we can help you, we'd be delighted to do so. So I hope that was very helpful, with the IRMAA discussion. And so we're going to take some questions. I just want to make sure everyone knows the number. We'd love to hear from you today. It is 833-824-2004, 833-824-2004. Give us a call about anything Medicare, Social Security, investments. We'd love to hear from you today. Now, we also have a Facebook group that I think right now 60,000 people or so that are in there. And if you have never joined our Facebook group, we encourage you to do so. A great place to dialogue with others that are on Facebook. Our staff is in there on a regular basis to keep the questions answered, accurately. Sometimes people will chime in and they don't always have the right opinion. And so our staff kind of monitors everything. But to be part of that, it's very helpful. Love to hear from people. And so if you're not a part of that group, please join that. And then we're going to actually take a couple questions from there. I think that could be helpful, and we'll discuss these. But this comes from a lady of the name of Robin in our Facebook group. It says, is there a document that I can take with me to my dermatology appointment that will help explain to the receptionist how my Plan G, which she has a Cigna HealthSpring, will be accepted as a supplemental plan? She kept telling me that provider was not in their network. Ooh. Okay. Also, for what it's worth, I made it known that I had 2 skin change spots that I want evaluated medically necessary. Okay. So you get this all the time. Yeah. All right. So let's just clarify just real quickly again. So she's saying, is there a document she can take to the dermatologist, say, hey, I'm on a supplemental plan? Why? Because the receptionist thinks I am not in network. You explain that, sir.
Absolutely. Yeah. And so, I worked in optical for 15 years too. So I helped people when it came to understanding their insurance and vision insurance and things like that. And that was easy for me. Mm-hmm. But then when somebody would come in with medical questions particularly on Medicare, they didn't give us any training on how that worked. I didn't understand what a supplement or what an advantage plan was. I didn't understand how this was supposed to be billed. They were not very clear with that. Right. So I'd say, I think it says on here you have a copay, and we're just going to bill this through, and you'll get a bill. That is not uncommon when it comes to how providers are trained, how this stuff is. And this is very much a provider issue, not a supplement or a Medicare issue. Everybody's a little bit different on how their training comes in. And so we're all trained to think our whole lives when it comes to insurance that this is network-based insurance. We got to make sure, is it in network? Is it accepted? Where can I take this? Where can I not take this? And so when we're dealing with Medicare and we throw all that out the window on a supplemental plan, there's no more networks. There's no more HMOs or PPOs or referrals or pre-authorizations or any of that stuff. We understand now, I can go to anybody I want as long as they take Medicare. They're going to accept my plan. But the provider themselves, they're going to see this is XYZ insurance. We don't take that one. So, we're not going to accept this. Like, no. I don't have to educate you on how this stuff works. I shouldn't have to educate you on how this stuff works. But in the end, you know what? It's okay. Well, all you have to do is take my cards, my Medicare card, my supplemental card. Here's my first, here's my secondary. Go ahead and bill them. And you're just going to send me whatever's left. You don't have to take in additional documentation beyond that. And if for whatever reason, and I've had this happen before, where a provider said, we're not going to bill your secondary. Fine. What I tell people in that case as a broker, send me the bill. I'll send it to your coverage, and this is going to get covered no matter what. They have to pay where A and B pay first. So don't worry if your provider decides to be non-compliant with your insurance. It's going to get paid no matter what. There's always it's set in the system. The federal government says they have to pay where A and B pay first. So don't worry about them not accepting it. You're going to get this huge bill. It will get paid no matter what.
Right. Yeah. So this is a training problem.
Yes.
Yeah. So this is a receptionist that doesn't understand the difference between supplemental plans and advantage plans. Yep. Advantage plans do not have to be taken by providers. Original Medicare and supplemental plans, they have to. Mm-hmm. So this truly is just a training issue. And so, as Evan said, no documentation, give them the cards. And it can be frustrating because sometimes people will call in advance to see if their plan is taken. So I tell people all the time, listen, if you're on a supplemental plan, you do not have to call the provider and ask them if they take your plan. If they take original Medicare A and B, they will take the supplemental plan. So don't even ask you because you're going to get an untrained receptionist that has no idea.
Yeah, and don't start saying carrier names either. When you're, just say, I got a plan G. You take Medicare? Great. You take my plan, I'll see you then.
Yeah, exactly. And 99% of all doctors take Medicare. They're going to take your supplemental plan. I would add, though, we have seen where there are times when a doctor only takes Advantage plans. And that's all they'll take. You know why? Because the Advantage plan owns them. Now, it's very rare, but it can happen. So if you're going to a doctor that only takes Advantage plans because they're owned by the Advantage company, then you need to find a new provider. And again, it doesn't happen often, but it does happen occasionally. But 99% of all doctors take original Medicare. So go where you want to go, and you may have to be the one that train the receptionist that they have to take your plan. So great question. All righty, let's keep going. We got another one from the Facebook group. And this person says, I have had sleep apnea for 16 years. My recent sleep study indicated no longer suffering from this due to a recent large weight loss. Doctor ordered another sleep study as the prior one did show some OSA, must be the acronym for sleep apnea, when sleeping on my back. My question is, will Medicare cover a second sleep study within a 6-month period? The typical cost for a sleep study before all the Medicare and other discounts is almost $8,000, so I'm concerned. Thanks for any insight into this concern. Any insight into that question?
Yeah, it's going to be the same with anything else that you're doing in Medicare. Everything you do has to be medically necessary and has to be ordered by the doctor. So there could be a lot of situations where Medicare wouldn't cover a second or a third treatment of this or that you're trying to do. But if the doctor orders it as medically necessary and they're coding it to Medicare as something that they ordered and they think is necessary, you can get coverage for those kind of things. But there's a general rule on how things generally go, and so you can follow those. But this is very much, once again, this is going to fall back on the provider. How is your provider going to be billing this specifically? And as long as they are billing as necessary, you're in the clear.
I would say this, and I think you're exactly right, Evan. I think that second opinions are not uncommon. Medicare will cover them. However, I agree with you. If I were you, and she doesn't give us her name, or he or she, but you want to make sure that the provider does their due diligence to make sure they're going to get paid. Okay, and so they can check into that. They can find out if indeed is there a code for a second opinion on a sleep study. And so I've never had this particular client ever ask me this question before, but the provider, I'd put it back on them. They want to get paid. And so they have a relationship with the Medicare offices so they can find out if it's covered or not.
It's a very safe blanket for everything in Medicare. Just make sure the provider's getting paid and make sure that they know what they're doing and how they're billing it. Because if you go in and you just start requesting stuff, you're requesting bills at that point.
Exactly.
So it's going to come right to you.
That's good. Great question, though. I've just never experienced it. All right. So someone else in our Facebook group says, I have Medicare with a supplemental plan G. I have a knee replacement I had a knee replacement in February, and I'm scheduled to have the other one done next week. But when my primary care physician entered pre-authorization blood test, he said Medicare is refusing to pay for 2 of them. The combined cost is $500. Does this sound correct? Any opinion on that one?
This is for the blood test, is what they're saying.
Exactly
Not the knee replacement, but the blood test.
Entered a pre-authorization blood test. He said Medicare is refusing to pay for 2 of them.
Okay, I would say I don't know, a broken record here. This is coming down to the coding done by the provider. So they put it in as something that maybe a pre-65 code or something that they're used to doing when it comes to blood tests and blood work as something that may not necessarily be coded as necessary. This is kind of a preemptive or a double check type of test kind of thing, in which case Medicare is going to look at that and they're going to reject non-medically necessary things. And so that could be very well what happened in this particular situation. Yeah,
exactly right. Yeah, I think if you have any doubt about that, you may want to call Medicare yourself. And if you call them, you could tell them the situation, and they may be able to give you something a little bit more direct. But I'm with Evan. I'd put it back on the provider. Say, hey, if this is something medically necessary, it should be covered. So are you sure that your prior authorization team actually did proper coding on it. That would be my opinion. So, yeah, some more homework's going to have to be done here on that one.
Yeah,
sure.
absolutely.
All righty. We have another one here. It says, has anyone had cancer in the group while on Medicare? Curious if it is better to have private insurance or if Medicare with a gap plan would be better.
Oh, yeah. I 38 years old. Next month, I'll be actually 39. If I could have Medicare today in a supplemental plan, I absolutely would. Even if it cost me twice what it costs people in many other states. Seeing how well it covers and what it's designed to do and how well it's accepted and how well providers
Yeah, well, define
get
what
paid.
you mean by that, though, when it comes to Medicare. Because
supplemental plan. Supplemental plan G. If I could have a G today, I would, but they don't let us have it till we're 65. I got 30 years to go before I can get on Medicare. I hope the system looks even remotely close to like it looks like today. The way that it is set up and the abilities you have to see the doctors and hospitals that accept it, the way that they get paid very happily by the federal government, which allows them the freedom and access to do what they want without being interfered with by an insurance company, is, from what I have seen, second to none.
Yeah, I would agree with you, too. I mean, I think if someone does have an Advantage plan, they certainly have coverage.
Sure.
But there could be some issues. There could be some network issues. They may not be able to go to the oncologist they want to, or even the hospital they want to if it's not going to be in the network. It doesn't mean to say they won't get taken care of, but the Advantage plans are going to give some limitations. It's just the way they work. So I agree with you. I think if I had the choice between a private health insurance plan, which could still be great insurance, but normally you're going to have a deductible, you're going to have max out of pocket that's pretty sizable. With Medicare, if I had that plan G, I have a B deductible, $283. I pay my premium, I'm done. As long as they take Medicare, I can go anywhere I want, which 100% of all hospitals do. 99% of doctors do, but Advantage would be totally different. Covered for sure, but pre-authorizations, network issues, all those kind of things could come into play.
And that's super elite hospitals, more and more of those. So this is what I tell people about places like the Mayo Clinic. You know, like they work very hard to make sure that you're getting cutting edge medicine, and some of that stuff's not cheap to get the kind of medicine and treatment that you want. But according to from an insurance company's perspective, if they have a chance to say what your treatment is, and they say, well, shoot, they want to do a $350,000 treatment, but this has been proven to be successful most of the time with the radiation pill. It's only $20,000. We're going to cover the radiation pill. And so that happens so often that eventually these elite hospitals that are trying to push through the edges and the boundaries of medicine say, we're not going to have to deal with these roadblocks anymore. Absolutely not. So no more Advantage. You know, we'll go with Medicare. Has a blindfold on and says, if you think it's necessary, we're going to pay you for it, and they'll write the checks, and they're good with that. And that's the kind of treatment I want. I want completely between me and my doctor and no one else in between.
Yep, very good. All right, that sounds good. Just one more here. Teresa says this, I just learned that the hospital in our area has dropped United Healthcare insurance due to disputes that cannot be worked out. So now I have to pay out-of-network cost. Can I change my supplemental insurance for this reason? Okay.
I think a little confusing on the terminology there.
Too.
Yeah, you said supplement. Obviously, supplement wouldn't matter because there's no networks unless you're, once again, the receptionist situation where they don't know. But I think what you mean to say is an Advantage plan. More than likely, I'm assuming if you're talking about networks, that's what you're referring to. This is where it can get a little bit tricky. Changing Advantage plans mid-year. Yeah,
let's pause for just a second, though. Okay, let's because I'm seeing this question differently. Okay, so I just learned that the hospital area has dropped United Healthcare insurance, so that hospital dropped United Healthcare Advantage plans.
Correct.
Okay. Yeah. It doesn't mean they dropped everything United Healthcare.
Right.
Certainly not supplemental plans. So pick up from there because that's the way I interpret the question. Keep going.
Right. Okay. And I interpret it the same way. It's just her wordage of supplement at the end of that was kind of the thing that threw me off.
I think she's probably on a supplemental plan. That's what I'm saying. Can I change my supplemental insurance for this reason? Gotcha.
You don't have to change. You're accepted exactly the same as you did before. When they say we're not taking XYZ insurances anymore, that's literally just we are out of the networks of the Advantage. We're not taking those.
Exactly right.
Original Medicare is still there. Your supplement's still there. That's not changing anytime soon. You're still accepted just like before. No difference.
That's right. They will not drop your United Healthcare supplemental plan.
Right.
They have every right to drop the Advantage plan if they choose to, we had this happen last year with Aetna. There were several hospitals that Aetna was no longer a network. And so we had people call, well, they won't take my Aetna supplemental plan. Oh, yes, they will.
Right.
They really, really will. So again, it's not across the board United Healthcare. It would be just the Advantage plan only.
Right.
Okay. So that's the way that works.
Yep.
Alrighty. Sounds good. Go back though. You were making a comment though.
Yeah.
About,
So
let's say she is on Advantage.
Let's say she is on Advantage. She just misused a word there and meant to say Advantage rather than supplemental. And so it's like, well, what do I do in that situation? And that is a common problem.
Right.
Doctors and hospitals switch networks mid-year. And so it would be really great if there was a golden code. This is what I would love if I was in Congress and make a change. I would add a code. I would have one golden change per year for whatever reason, like doctors changed networks, and you could make that change. But there is no golden code for that. Unfortunately.
Not yet. You're right.
Not yet. Hopefully soon. Whoever's listening in the powers that be, please put a code in there. That would make everyone's life
just so
much
you know,
easier.
they tried.
They did.
I've got an article right here in my notes. Listen to this. Help for Medicare Advantage patients who lose doctors is shelved for now. Yeah, they just tried to do this. They tried to put in a code for people mid-year in case this happened, and it did not make it through. So, well, you know why? Insurance companies fought that like crazy. Right. They don't want that. They don't lose that client.
Yeah. Gain that client. I mean, it can go both ways, obviously, but some of them aren't looking to gain people right now. They're looking to shore up what they have, if not maybe cut down in some areas. So I can see where that.
Yeah, but once they had that client on the books, they're not interested in them being able to get off of that.
True.
They're getting that payment on a monthly basis. So I know it could go either way, but I think the big thing is insurance companies fought this because they don't want another SCP code.
They want to keep it.
Yeah. So let's talk about this situation. So if someone does have this happen, if they're in the midst of treatment, there will be a continuance of coverage. But if you're not in the midst of treatment, then you're going to have to go find a new hospital.
Right. Or at least until AEP at the end of the year when you get a chance to switch to somebody else who is in the network. Once again, going to have to be watching that is because they could announce we're going to be in network with this new carrier, and by the end of the negotiations end, it's March or April the next year and fell through. Didn't work out. And so there are a few election codes throughout the year. You got the AEP, you got the OEP in the first quarter of the year. Just in case something like that occurs, you can make one change, to kind of help you out.
But tell them the dates on that. I think that's important.
Going to be the first quarter. So January 1st through March 31st is OEP. That's after you've made your selection during annual enrollment, October 15 through December 7, and something changes and something isn't quite what you thought what was, or your hospital announced it's not going to be what you thought it was going to be for networks. You have that opportunity. Those two sections. That's realistically almost half the year. So you got the last quarter and the first quarter realistically to make changes. If something happens in the middle of the year, sometimes there are election codes to make changes. You can't change every month, but some things might come up. Right. They're not a guaranteed switch for this or that, depending on your circumstance. Ask your broker, of course, and see, hey, is there any way I can try to make this change if necessary? And this is really only going to be in one of those situations where I've got to see my doctors and hospitals. I refuse to change, or I'm in an area where there's one hospital. The next one is 100 miles away. And I only have this plan they don't take, and I'm in an HMO. What do I do? And so this is where you really try to find there's no guarantees that you can make that change.
And this is one of the beauties of supplemental plans that everyone needs to realize. You will not deal with this kind of thing with the supplemental plan.
Right.
100% of hospitals take original Medicare. They'll take your supplemental plan, and they're going to continue to do so.
Right.
That's just the way it works. And again, not bashing Advantage plans because there's a place for them. But when people pay a premium, this is why they do so, because they don't want to lose their coverage. They don't want to have to worry about year to year, is my doctor in the network any longer? Okay, so we eliminate those frustrations.
There's few situations where supplement versus advantage, not supplement versus supplement, but supplement versus advantage is kind of a get what you pay for. If you put something into it, you will get something out more than just the unknown price that you can get for a $0 premium.
I've been doing this now, insurance, 17 years, 15 years in Medicare. And I've had lots of doctors, nurses, coders, all kinds of people in the medical field. And honestly, I've never had one that I'm aware of ever go on an Advantage plan. Not one time in my whole career. Okay. And so I'm not saying it doesn't happen, but it's never happened to me.
Right.
And the reason for that is because the people in the medical field see what happens when people need to go through a pre-authorization, it gets denied or it gets delayed, and they're saying, I don't want that to happen to me.
Right.
It's kind of like a mechanic that knows usually when the transmission is going to go out on a car or when there's going to be problems with a car because they're under the hood every day. They see the problems mechanically.
I'll never own XYZ car ever.
Yeah, they say it all the time.
Problem. Yep,
yeah, that's right.
Absolutely.
So that's the way it is in the medical field when it comes to insurance. They see what happens with people on Advantage plans. Had a gentleman recently on Advantage plan, went to skilled nursing facility, 13 days. And then they said, we're done paying for his skilled nursing bill, send him home. And so, again, that wouldn't happen in original Medicare.
Right.
Average stay, 45 days right now. So those kind of things happen. So I say all that because people need to be mindful that when you pay a premium for a supplemental plan, you are getting something out of it.
Right.
You are. Almost unlimited providers, no pre-authorizations, permanent plans, portable plans, so there's a lot of benefit to that. All right. So,
yeah. And awareness of our own mortality when it comes down to it too. We're all getting older and things aren't going to be like they were. I mean, people say I've been healthy my whole life. I've never been to the hospital. Great. I hope it stays that way.
Exactly.
I really hope it does. Statistically, not as likely, but this is where you have to plan ahead.
Right. Yeah. Had a guy recently that wrote me, and I did not deal with him. One of our agents did, but he wrote me and said, Marvin, we went with the supplemental plan, though both he and his wife are healthy. And he said within 1 year, he was diagnosed with prostate cancer and his wife had a heart attack. And they went with supplemental plans. He said, we're very glad that they did. They looked in the mirror that day and they made a decision. I can't just be thinking about my health today.
Right.
Because it could change. And it did change for them, very drastically.
Yeah. Many stories like that myself.
Exactly.
Absolutely.
Right. Yeah.
Yeah.
And we got two other great questions here.
Yeah.
Let's get to these, and then we'll be concluding for today. But I thought this was really good. Someone who turned 65. Here's the question: someone who turned 65 in January and is uninsurable decides to go with his former employer's retiree group Medicare Advantage plan. He decides at a later date to switch to a Medicare supplemental plan. Would that be a guaranteed issue, or does he have to drop the group Medicare Advantage plan within 6 months of getting Medicare Part B and use open enrollment? Thank you. Okay, you got it? That's loaded. So someone turns 65, uninsurable, decides to go with this former employee's retiree group Medicare Advantage plan.
Yep.
Okay.
Got it.
Good.
Yeah. So, first of all, it's the second part of that where you have to do it within the first 6 months because if you said guaranteed issue is only going to be if they're taking it away from you and it's through no fault of your own. Involuntarily. You can't just end the policy and say, hey, I lost my plan because they have to have proof that they ended it. They terminated. You moved out of the area. Something where you're losing it through no fault of your own. So you can't set your watch by those things. We don't know when those things are going to happen. So you be rolling the dice when that opportunity may come to you in the future. So you would have to do it in that first 6 months. Obviously, if you're a super healthy person and you never go to the doctor and never take meds, you can once again roll the dice and maybe change later on down the road through underwriting. But as far as guaranteed acceptance, you want to make sure it's in that first 6 months.
Exactly right. Yeah. So very good. So just know, folks, once you've started that Medicare B, you have that 6 month window, which includes your birth month. So if my birthday's in January, I've got all the way through the end of June, 6 month window, no underwriting. So you'd want to make that switch then for sure.
Right,
Okay.
right.
Yeah. If it was involuntary, meaning that the plan dropped you, then it would be different. You would have a extended guaranteed issue period.
Right.
But don't roll the dice in something like that. I agree with you totally. Okay, just one more. This lady says, my husband is going to be prescribed the new med in a few weeks. It is not on his formulary. What can I or the doctor do to see if they will cover it?
Gotcha. Yeah, definitely ask your doctor and talk to you about that. They may there may be alternatives to that medication. If it's not in the formularies of Medicare, there's going to be potentially step therapy where they may want to do a lower cost or a different type or something else. If there is no alternative and the doctor says, nope, this is it, and I know your tolerances. We can't take this generic or that. We've tried it, or it's not. You're something you may be allergic to, or there's just I will not prescribe anything other than this particular medication. Then it's when you're going to start working through the prior authorizations and trying and the formulary exceptions to try to get the insurance companies to pay that. Will you know ahead of time that is going to be covered? No. There's really no way of guaranteeing that an insurance company is going to cover a specific medication. There's a good chance, if the doctors are on board, that they're not going to provide anything alternative, and this is a medically necessary medication that you need, that you will get what you need out of it, but it's no guarantees that they have to do that.
But I think as a general rule, we could say that normally,
yes.
Normally you're going to get a formulary exception, and I would just be proactive if it were me. Get on it. You say here in a couple of weeks, have the doctor write the prescription, and if it is denied, now you've got some time. You can go through that formulary exception process. Okay, so that's what I would do. So because I think as a general rule, the Part D plans do everything they can to make sure people are getting the proper medication. But it is true. If there's equivalents, alternatives that are cheaper, generics, you're going to have to try those.
Right.
But if not, I think you'll get it approved.
Right.
Okay.
And if doctor's not real hard line with the insurance company too, to say, yeah, well, no, we haven't tried this other thing, but I prefer they stay on this one. It might not be enough. Insurance company might say that's not a good enough reason for us.
And if you do get denied on something like that, then always appeal. I think what 70% of all appeals go through. I think they ought to approve the first time, but sometimes people do have to appeal. So you'll probably be successful in getting that medication, more than likely.
More than likely.
Yeah. All right. Great question, though.
Yep.
All right. So that's going to be it for today. Evan, enjoyed, as always, being with you.
Absolutely.
Appreciate all your hard work as you serve people around the country. Now, tomorrow's broadcast, we're going to be talking about specifically about cancer. We're going to look at the issues of that cancer coverage, whether you're on a MedSup plan or a Medicare Advantage plan. We'll get into the details about those two types of coverage if indeed someone got that cancer diagnosis. Now, if you need any help, folks, let me just give you our number. You can call in to get help with an agent such as Evan. You can call 800-782-6676. That's 800-782-6676. If you need immediate help, our office is open Monday to Thursday, 7 to 7 a.m. to 7 p.m., then on Friday, 7 to 6. So we'd be delighted to serve as your broker. And as always, there's no cost when you use a broker, and we'd be delighted to serve you in any way. Take care.